Hello, my name is Randall Thomas. I'm Medical Director for Cardiac Rehabilitation at the Mayo Clinic in Rochester, Minnesota. I'd like to talk to you today about cardiovascular risk calculators. First of all, why use cardiovascular risk calculators? Cardiovascular risk factors explain a large part of cardiovascular disease. In fact, we know that cardiovascular disease is generally preventable based on a relatively small handful of factors that are thought to cause the majority of cardiovascular disease. Because we know that a focused approach to prevention on higher risk individuals is generally thought to be the most cost-effective means of prevention, using a means to calculate risk can help us identify patients who would be at highest risk and therefore most likely to benefit from interventions. How do we calculate cardiovascular risk? Well, as Yogi Berra once said, it's tough to make predictions, especially about the future. When we want to calculate cardiovascular risk, we must consider a few things. First of all, again, a small handful of factors cause the majority of cardiovascular disease. This may make it a little bit easier to then calculate cardiovascular risk. Population studies show the relative impact of cardiovascular disease risk factors, which also helps us to quantify the impact of those factors. The best studies, however, need large populations and many years of follow-up to show us the true impact of these cardiovascular risk factors. Unfortunately, when we need to wait for many years to find the results, many things can happen in the interim, including new treatments, new risk factors might be identified, and so this is a problem as we try to identify the true impact of cardiovascular disease risk factors. No study or cohort is perfect with regards to the data they provide or the guidance they give to us. So in other words, cardiovascular risk prediction is hard. It takes time and a lot of patience to be able to identify how we can best predict risk. What is the current standard for calculating cardiovascular risk? Currently, the 10-year pooled cohort cardiovascular risk calculator is the standard that is used for most clinical practice guidelines. This calculator uses data pooled from studies including the ERIC study, the Cardiovascular Health Study, the Cardia study, and the Framingham Original and Offspring study cohorts. The calculator uses age, sex, race, smoking habits, blood pressure, cholesterol levels, and diabetes status to help estimate the future risk of cardiovascular disease. This estimates the risk of a non-fatal myocardial infarction, a fatal coronary heart disease event, or stroke. The estimated risk guides the intensity of preventive therapies. The higher the risk of a patient, the more intense the therapy. Simple, practical tools are available for clinicians and patients to use this calculator. However, there are challenges to this calculator. The calculator does tend to overestimate true risk based on a number of studies. The tool is not applicable to all racial and ethnic groups. The tool does not include genetic factors, including family history, nor does it help as well patients who are younger, those younger than age 50, those who are at lower risk generally. There are other cardiovascular risk calculators, including LifeSimple 7 from the American Heart Association that uses lifestyle habits, cholesterol, blood pressure, and blood sugar levels. Fuster BWAT, which uses blood pressure, exercise, weight, alimentation or diet, and tobacco habits, a simple approach. The MESA study that uses risk calculating factors for 4 racial and ethnic groups. They also use coronary calcium in that calculator. And then the Framingham 30-year risk calculator, especially good for patients who are younger than 50. So how do we put this all together? For patients 25 to 75 years of age, we would recommend using a cardiovascular risk calculator and also assessing family history, particularly looking for any male relatives younger than 55 or female relatives younger than 65 who have had heart disease. The risk calculator could include, in a clinical setting, the pooled cohort estimator, or if you're looking at a population health setting, something like the Life Simple 7 or the Fuster BWAT may be good options to consider. For lower resource settings, the Fuster BWAT score may be more advantageous given the simplicity of its approach, yet it's still very accurate. For patients younger than 25 to 55 years of age, the Framingham 30-year risk score can be used to give more guidance and to identify those younger individuals at higher risk. And for those with a positive family history or those with intermediate levels of risk based on the other calculators, additional testing can help clarify the risk of a patient, including lipoprotein A, inflammatory markers such as high-sensitive CRP, and others. Imaging could be considered, including coronary artery calcium scanning, or carotid intima media thickness, or even ankle brachial index measurements to help clarify a patient's cardiovascular risk. Where are we going in the future with risk calculation? Well, this is one example of where we may be heading. This is from a study using artificial intelligence techniques, mainly machine learning techniques, to study the risk calculator impact of such a tool. What they did was, in this study, they used the MESA cohort, and they applied this machine learning algorithm to see how well the risk calculator worked to identify people who would qualify for receiving statin therapy because of at least intermediate levels of calculated cardiovascular risk. On the right here, you can see the results. Compared to the pooled cohort calculator, this new machine learning calculator identified 11% of patients as being eligible for statin therapy compared to 46% in the pooled cohort estimator. So fewer people were identified as needing statin therapy, and when you looked at those who did not receive statin therapy, how many had a cardiovascular event, so-called missed opportunities, it actually showed counter than what you might think, that the machine learning tool actually did better at helping to avoid those missed opportunities. In other words, fewer people needed statins, and of those who didn't go on statins, fewer had cardiovascular events when using the machine learning tool. This was applied for the hard cardiovascular events, as I mentioned previously, but also for all cardiovascular events that include some of the softer events as well. So really quite a remarkable outcome to help us have more accuracy in identifying people at risk who might benefit from more intensive therapies. Well, the take-home points are as follows. Estimating cardiovascular risk helps to guide the intensity of preventive therapies by identifying people at higher risk for disease who may benefit from more intensive therapies. The current tools that we have are helpful, but they're not perfect. Future tools will likely help improve the accuracy of risk calculation, including tools such as artificial intelligence and machine learning tools that can guide our risk calculation. Thank you very much, and good luck in your risk calculations.